So children, today we'll be starting with chapter 33rd of the Apurba Sastry Essentials of Microbiology, which is HIV and AIDS. In this part, we'll be covering morphology, pathogenesis, clinical diagnosis, and epidemiology, while the lab diagnosis and post-exposure prophylaxis will be covered in the subsequent parts. So starting with introduction and morphology. Retrovirus are a group of RNA viruses that possess a unique enzyme called reverse transcriptase, which directs the synthesis of DNA from viral RNA after they infect a host cell. They belong to family Retroviridae, which comprises of several genera, out of which two genera contain viruses that are pathogenic to humans. Genus Lentivirus contains human immunodeficiency virus HIV 1 and 2. Genus Delta Retrovirus contains human T cell lymphotropic virus 1 HTLV1. Human immunodeficiency virus HIV is the etiologic agent of acquired immunodeficiency syndrome AIDS, the biggest threat to mankind in the last 3 decades. Origin or history of AIDS. The first case of AIDS was described from New York, USA in 1981, which was soon followed by the discovery isolation of HIV-1 from Pasteur Institute, Paris in 1983. HIV in humans was believed to be acquired from chimpanzee by the cross-species interaction of simian counterpart of HIV, simian immunodeficiency virus or SIV-CPZ in rural Africa. It has been postulated that though the zoonotic transmission to humans was going on repeatedly over many years in the past, only by the late 20th century the virus underwent changes which enabled it to adapt to human environment and reach the epidemic level. Structure. HIV and other lentiviruses have unique structure as we'll see in the figure. They are spherical and 80 to 110 nanometers in size. Envelope. HIV is an enveloped virus. The envelope is made up of lipid part is the host cell membrane derived. Protein part, it has two components, glycoprotein 120, GP120. They are projected as knob-like spikes on the surface, and glycoprotein 41, GP41, they form anchoring transmembrane pedicles. The nucleocapsid is an icosahedral symmetry made up of core protein. Inside there is a 10 cylindrical inner core which encloses RNA, two identical copies of single stranded positive sense linear RNA, viral enzymes such as reverse transcriptase, integrase and protease, which are closely associated with HIV RNA. So in this figure we can see the envelope, which consists of GP120, GP41 and the lipid membrane. Inside is the core, which contains two copies of single-stranded RNA with reverse transcriptase enzyme. Alright. So, HIV genes and antigens. HIV contains 3 structural genes, GAG, POL and N, and 6 non-structural or regulatory genes. The structural genes. Structural genes code for virus components of the virus. The GAG codes for core and shell of the virus. It is expressed as a precursor protein P55, which is cleaved into 3 proteins. P18 constitute the matrix or shell antigen. P24 and 15 constitute core antigens. Now it says in HIV the protein and glycoprotein are indicated by the mass, which is expressed in kilodaltons. P55 means protein with molecular weight of 55 kilodaltons. Alright. Now the Pol gene codes for viral enzymes such as reverse transcriptase, protease or integrase. It is expressed as a precursor protein which is cleaved into proteins P31 integrase, P51 reverse transcriptase and P66. The N gene codes for the envelope glycoprotein GP160, which is cleaved into 2 components, GP120 and GP41. It is GP120 is the main receptor of HIV that binds to CD4 molecules on host cell to initiate the infection. GP41 is a fusion protein. Now the non-structural genes. The non-structural genes regulate the viral replication and are important in disease pathogenesis in vivo. They can be grouped into essential regulatory genes, TAT, transcriptional transactivator, NEF, negative factor, and REV genes. Accessory regulatory genes with viral infectivity factor, VPR and VPU genes. Antigenic variation and diversity. HIV shows extensive antigenic diversity as it undergoes high rates of mutation. This is believed to be due to error-prone nature of the reverse transcriptase enzyme. Different mutations will be selected under different conditions, host factors, immune responses, and tissue types. Although mutations may occur in any genes, most notably it is observed in N gene. Unfortunately, the envelope proteins happen to be the major target against which antibodies are produced. Hence, mutations in N gene are the main reason, which explains why HIV evades the host immune response. Vaccination against HIV is extremely difficult. HIV serotyping. Based on sequence differences in N gene, HIV comprises of two serotypes, HIV1 and 2. HIV1. It is divided into three distinct groups, M and O. Recently, HIV strain related to gorilla SIV was identified in a Cameroonian woman in 2009 and has been proposed as Group P. M is the dominant group worldwide. It comprises of 11 subtypes or clades A to K. Subtypes are sometimes further split into subtypes such as A1 and A2 or F1 and F2. There are also circulating recombinant forms or CRFs derived from recombination between different subtypes. For example, CRF01 underscore AE is a recombination between subtypes A and E. The same infected host may have group of closely related viral subtypes and or CRF at given time, which are collectively called as quasi-species. HIV-1 subtypes or clades do not vary in pathogenesis or biology, but they differ in geographical distribution and transmission. Geographical distribution. Subtype A is common in West Africa. Subtype B is predominant in Europe, America, Japan, and Australia. Subtype C is most common form worldwide, 47%. It is also the dominant form in southern, eastern Africa, India, and China. Greatest diversity. In Cameroon, West Africa, all known HIV groups and subtypes are found. It is probably considered as the place of origin of the virus. Transmission. Asian and African subtypes C and E are more readily transmitted heterosexually, whereas American strain subtype B preferentially spread through blood and homosexual contact. HIV-2. It comprises of 8 subtypes A to H. They are mainly confined to Africa and few other places including India. Group A is the most common form. Pathogenesis. Mode of transmission. HIV is transmitted through the following modes. Sexual route is by far the most common mode of transmission, accounts for 75% of total cases in the world. Heterosexual route, male to female via vaginal coitus, is the commonest mode. However, the risk of transmission through sexual route is minimal, 0.1 to 1% per coitus. Anal intercourse among homosexual males or even male to female has high risk of transmission than vaginal intercourse. Blood transfusion is the least common mode of transmission, 5%, but the risk of transmission is maximum, 90 to 95%. So in the table we can see the transmission of HIV. Route of transmission, blood transfusion, risk of transmission is more than 90%. In the world it's 5%, in India it's 1%. Parent to child is 13 to 40%. Sexual intercourse 0.1 to 1, in which vaginal accounts for 0.05 to 0.1. Anal accounts for 0.065 to 0.5. Oral accounts for 0.005 to 0.1. Injection drug abuse accounts for 0.5 to 1.0. And needle stick exposure accounts for 0.3. Alright, so now the percutaneous or mucosal transmission modes such as needle stick injury or injection drug abuse and sharing razors or tattooing or splashes of infected blood on eyes, etc. are among the less effective modes of transmission. Perinatal mode. In the absence of any intervention, the risk of transmission from mother to fetus is about 20 to 40%. Transmission may occur at any time during the pregnancy and breastfeeding, but the risk is maximum during delivery. Now, the risk is maximum if the mother is recently infected or has already developed AIDS. There is no evidence of HIV transmission by casual contact or kissing or insect bite. Viral load is maximum in blood, genital secretions, and CSF, variable in breast milk and saliva, zero to minimal in other body fluids or urine. Saliva may contain inhibitory substances like fibronectin and glycoproteins, which prevent transmission of the virus. Receptor attachment. The following receptor interaction is essential for HIV entry into the host cell. Main receptor. HIV enters into the target cell by binding its GP122CD4 receptor on the host cell surface. CD4 molecules are mainly expressed on helper T cells and also on the surface of various other cells like monocytes, macrophages, Langerhans cells, astrocytes, keratinocytes, and glial cells. A second co-receptor in addition to CD4 is necessary for fusion of HIV to gain entry into the host cell. Usually, the chemokine receptors act as co-receptors for HIV and act by binding to GP120. Examples include CXCR4 molecules present on T lymphocytes, CCR5 molecules present on cells of macrophage lineage. DC sign. A dendritic cell-specific lectin receptor present in skin and mucosal surfaces can also bind to HIV-1 but does not mediate cell entry. Rather, it may facilitate transport of HIV by dendritic cell to lymphoid organs where HIV replicates further in the T cells. Mutation in CCR5, delta 32 mutation. This mutation results in blockade of HIV entry into the cells. It is observed principally in some lucky people of Europe and West Asia who are either completely resistant to HIV infection if they are homozygous for delta 32 mutation gene seen in 1% of northern Europeans, particularly in Sweden, or susceptible but progression of AIDS is delayed if they are heterozygous for the same gene seen in 10 to 15% of Europeans. Now we come to the replication of HIV. The replication of HIV, which is given in previous chapter also, it occurs through the following steps. First, fusion. Following attachment of receptor and co-receptor to GB120, fusion of HIV to host cell takes place mediated by fusion protein GB41. Penetration and uncoding. After fusion, HIV nucleocapsid enters into the host cell cytoplasm, which is followed by uncoating and release of two copies of ssRNA and viral enzymes. Reverse transcription. Viral reverse transcriptase mediates transcription of its ssRNA into ssDNA so that DNA-RNA hybrid is formed. The RNA is degraded by viral endonuclease and ssDNA replicates to form dsDNA. Transcription of the DNA occurs to form some of the components of viral proteins. The pre-integration complex. The nucleoprotein complex formed comprises of linear dsDNA, GAG matrix protein, accessory VPR protein, and viral integrase. This is called pre-integration complex, which is transported into the host cell nucleus. Integration. The viral dsDNA gets integrated into the host cell chromosome mediated by viral integrase. The integrated virus is called as provirus. Latency. In the integrated state, HIV establishes a latent infection for a variable period. However, HIV is different from other latent viruses as it is able to replicate even in latent state and is infectious in other neighboring cells. The disease progression. Patients infected with HIV undergo various types of disease progression, which is given in the table, which in turn depends upon the various factors such as host, viral, and environmental factors. The natural course or the typical progressors. About 80 to 90% of HIV infected individuals are typical progressors with a median survival time of approximately 10 years. The typical course of HIV infection includes the following 5 stages given in the table. Okay, the typical progressors within 10 years they develop AIDS, and it is in 80 to 90% of the patients. The rapid progressor they develop within 2 to 3 years, seen in 5 to 10% of the cases. Long term non progressor and LTNP they develop after a very long time, like 10 to 30 years without ART. They show less than 5,000 HIV RNA copies per ml, usually associated with CCR5 mutation, seen in 5% of the cases. An elite controller subset of LTNP after a long time, 10 to 30 years without ART, they show less than 50 RNA copies per ml below detectable level, and seen in less than 1% of the patients. Okay, now first, acute HIV disease or acute retroviral syndrome. Following infection, HIV is carried into lymph nodes and other lymphoid tissues where further multiplication occurs inside the T cells. Initially, HIV destroys the infected T cells and spills over into the bloodstream to cause primary viremia or acute mononucleosis like syndrome, which coincides with an initial flu like illness that occurs in many patients, 50 to 75%, 3 to 6 weeks after the primary infection. There is a significant drop in the number of circulating CD4 T cells at this stage. Second, the asymptomatic stage or the stage of clinical latency. Adequate immune response developed within 1 month in most of the patients. Both effective cell-mediated immune response, HIV-specific CD8 T cells, and humoral immune response, HIV-specific neutralizing antibodies, come into play. As a result, viremia drops down and CD4 T cell count becomes normal. It is important to note that this is a state of clinical latency but not microbiological latency. The immune response cannot clear the infection completely. HIV infected cells persist in the lymph nodes and there is a high level of ongoing viral replication. This period of clinical latency is variable, may last for 10 years but ranges from few months to 30 years. However, once the latency is broken, the disease progresses rapidly and the death usually occurs within 2 years if left untreated. Third, persistent generalized lymphadenopathy (PGL). As a result of HIV replication in lymph nodes, 20-30% of infected people who are otherwise asymptomatic develop lymphadenopathy. PGL is defined as enlarged lymph nodes of more than 1 centimeter size in 2 or more non-contiguous sites that persist for at least 3 months. Okay, this will be called the persistent generalized lymphadenopathy. PGL must be distinguished from other causes of lymphadenopathy such as lymphoma. Fourth, symptomatic HIV infection age-related complex. After a variable period of clinical latency, the CD4 T cell level starts falling. Eventually, patients develop constitutional symptoms such as unexplained diarrhea lasting for more than 1 month, weight loss more than 10%, fatigue, malaise, and night sweat, mild opportunistic infections such as oral thrush. AIDS. Gradually, the patient moves towards the advanced end stage of HIV infection called AIDS, characterized by rapid fall in CD4 T cell count, usually less than 200 cells per microliter, high viral load, lymphoid tissue is totally destroyed and replaced by fibrous tissue. Opportunistic infections set in secondary to profound immune suppression. Depending on the CD4 T cell count, various infections occur, as we'll see in the figure. Development of neoplasia, CNS lymphoma, development of direct HIV induced manifestations such as HIV encephalopathy. Now in this figure we can see that the figure A shows the natural course of infection, in which the blue line represents the fall in the number of CD4 T cells, while the red line represents the stages, like in first stage the possible acute HIV syndrome occurs, then the period of clinical latency, then constitutional symptoms, and finally death can occur. Now, the second figure shows the opportunistic infection associated with HIV infection and the correlation with CD4 T cell counts, like the bacterial skin infection, HSV, fungal infection, Kaposi sarcoma, hairy leukoplakia, tuberculosis, PCP, cryptococcosis, toxoplasmosis, MAC, CMV, and lymphoma. Okay, now we start with the clinical diagnosis of HIV. Classification system for HIV disease have been developed which are useful for tracking and monitoring the HIV epidemic, for providing clinicians and patients with important information about HIV disease stage and clinical management. Two such systems are currently in use worldwide: CDC classification system and WHO clinical staging of HIV or AIDS. First, the CDC classification system, Center for Disease Control and Prevention, revised 1993. This system classifies HIV infection into 9 stages based on associated clinical conditions and CD4 T cell count of the patient. WHO clinical staging, World Health Organization revised in 2007, is based only on the clinical conditions associated with the patient. For resource poor countries like India, where facilities for testing CD4 T cell count are not available widely, WHO clinical staging is more useful. It classifies HIV infection in adults and adolescents more than 15 years into 4 stages, like we can see in the figure. In clinical stage 1, asymptomatic HIV infection with persistent generalized lymphadenopathy is categorized. Clinical stage 2 accounts for unexplained moderate weight loss less than 10%, recurrent respiratory tract infections like sinusitis, tonsillitis, otitis media, and pharyngitis, herpes zoster, angular cheilitis, recurrent oral ulcers, papillopruritic eruptions, seborrheic dermatitis, and fungal nail infection. Clinical stage 3 includes unexplained severe weight loss more than 10%, unexplained chronic diarrhea more than 1 month, unexplained persistent fever 1 month, oral candidiasis, oral hairy leukoplakia, pulmonary tuberculosis, severe bacterial infections like pneumonia, empyema, etc., acute necrotizing ulcerative stomatitis, gingivitis, and periodontitis, unexplained anemia, neutropenia, and chronic thrombocytopenia. Clinical stage 4 includes HIV wasting syndrome, Lyme disease characterized by profound weight loss more than 10%, chronic diarrhea more than 1 month, prolonged unexplained fever 1 month. Bacterial opportunistic infection, recurrent severe bacterial infections, extrapulmonary tuberculosis, disseminated non-tubercular mycobacterial infection, recurrent septicemia including non-typhoidal salmonellosis. Viral opportunistic infection, chronic HSV infection, progressive multifocal leukoencephalopathy, CMV, retinitis, or infection of other organs, fungal opportunistic infections, pneumocystis, zero-vesi pneumonia, esophageal candidiasis, extrapulmonary cryptococcosis, meningitis, disseminated mycosis, histoplasmosis, and coccidiomycosis. Parasitic opportunistic infections like toxoplasma encephalitis, chronic intestinal cystosporiasis more than 1 month, and atypical disseminated leishmaniasis. Neoplasia, Kaposi sarcoma, invasive cervical cancer, and lymphoma like cerebral and B-cell and non-Hodgkin lymphoma. Other conditions direct HIV induced are HIV encephalopathy and symptomatic HIV induced nephropathy or cardiomyopathy. So this is the clinical staging of HIV/AIDS based on WHO criteria. Now we start with the epidemiology. Global situation till the end of 2018 is given here, and 21 is given in the latest edition. So we'll be covering the latest edition data. Till the end of 2021, about 38.4 million people were living with HIV with a global prevalence of 0.7% in adults. Incidence in 2021, 1.5 million new HIV infections occurred globally with 6.5 lakh deaths. South Africa was the highest number of people living with HIV in the world, 7.5 million, whereas Eswatini has the highest prevalence in the world, 27%. World AIDS Day. Globally, 1st December is observed as World AIDS Day every year. Situation in India till the end of 2021. HIV prevalence in India was reported as 0.21% in adults, and it continues to have steady decline since 2000, which was 0.54%. The northeast states such as Mizoram, Nagaland and Manipur have the highest prevalence. PLHIV, number of people living with HIV, was 23.2 lakh. Maharashtra was the worst affected state, followed by Andhra Pradesh, Karnataka, Uttar Pradesh and Telangana in terms of PLHIV. Alright. Now comes the reservoir. Infected people, both symptomatic as well as asymptomatic, are the only reservoir host. Once infected, they are harbor the virus for lifetime. High risk groups. Extremely high risk groups which commonly acquire infection are female sex workers, men who have sex with men, hijra or transgenders, and IV drug abuser group. Moderately high risk group, healthcare workers via needle pricks or splash injury, hemophiliacs and other recipients of blood products, people with other STI sexually transmitted infections. Next comes the opportunistic infections. Globally, including India, tuberculosis is the most common opportunistic infection that occurs in HIV infected people. Okay. Common fungal infections are candidiasis, oral thrush, and pneumocystis jirovecii. Frequent viral infections are herpes simplex, mucosal lesions, and CMV retinitis. Common parasitic infections are cryptosporidium, parvum, diarrhea, toxoplasma encephalitis, and strongyloids stercolis hyperinfection syndrome. AIDS control organizations, UNAIDS, the Joint United Nations Program on HIV and AIDS, UNAIDS, is the main advocate for global action on HIV or AIDS. It has initiated the fast track strategy to end the AIDS by 2030. NACO. The National AIDS Control Organization NACO has been constituted to implement the HIV or AIDS control program in India. It provides single national plan with one monitoring system. SACS, the State AIDS Prevention Control Organization, have present in every state. They implement the NACO program at state level. National Strategic Plan for HIV or AIDS and STI 2017 to 2024, NACO has launched the National Strategic Plan paving way for an AIDS-free India, going in line with UNAIDS for ending AIDS epidemic by 2030. Kinetics of immune response. Okay, understanding of the kinetics of host immune response is following the infection is needed before we discuss the lab diagnosis, so as to understand the optimal usage of various tests during the different stages of HIV disease. First, viremia. Soon following the entry of virus into the body, there occurs a transient period of high level of viremia and P24 antigenemia. Okay, however, the levels of these components fall down with concomitant immune response. Humoral response is evident by the formation of antibodies in different classes IgM, IgA, IgG against different structural proteins GAG, B15, B17, P24, P55 and GP41, GP120, GP160 and POL, P31, P51 and P66 regulatory proteins, NEF, REV, TAT and accessory proteins VIF, VPU and VPR. All structural components are strongly immunogenic and induce formation of antibodies, whereas immunogenicity of regulatory and accessory proteins is variable. Window period. Following infection, antibodies appear in serum only after a period of interval, which is called window period. This is about 3 to 12 weeks. The antibodies to GAG protein P24 and P55 usually appear first, though antibodies to N proteins and POL proteins may also be produced simultaneously. As infection progresses to AIDS, antibody P24 usually declines, and as P24 antigen levels rise concomitant with progression of disease to AIDS. However, antibodies to N proteins persist throughout the infection. All right. Anti-HIV antibodies, among the antibodies IgA, IgM, and IgG that appear, only IgG response is consistent and long-lasting. Most currently is available assay detect IgG antibodies. However, detection of IgA is useful in specimens such as serum, mucus secretion, and in newborn. Now, first, let us see the fast track strategy ending the AIDS epidemic. It's just about knowledge of the patient, knowledge to the patient about that he's having a disease. Like percentage of infected people should know about the disease status. Present was in 2016 was 70%. By 2020 it was aimed to 90% and to be increased. And then percent of infected people receiving antiretroviral treatment should increase. Percentage of people receiving ART have viral suppression. It should also increase. New infection among adults should decrease. And to eliminate HIV related stigma, we are always trying to do this. Now, lab diagnosis of HIV. Specific test for HIV infection. We'll be seeing it in a short while. Okay. So that's all for today's video. Make sure to like, share, and subscribe the channel. Thanks for watching.